Not a problem.
Uh, Hi guys and namaskar. Very warm welcome to today's Critical Lines. And it is my pleasure and privilege to introduce Dr. Babu Ibrahim sir to you, all of you. So sir, I think needs no introduction to most of you. He is senior consultant in Apollo Chennai. He's pulmonary and critical care, as everybody knows, and we all know how good and ICU we have in Apollo Chennai. Sir is also an examiner for all the examinations. If that is the DNRB, the ICCM, IFCCM. So it'd be very relevant to hear from him for all the examinees. And of course, he's been involved in all the examinations and teachings. He has been the vice chancellor for the Indian College of Critical Care Medicine. So I think, especially for the trainees, it'll be very useful to hear what Sir has to say today. So without further ado, I'll start off. So, sir, the first question for you to discuss is about plateau pressure and intra-abdominal pressure. So we know that in cases of ARDS, we have an upper limit of 30. Some people say now 27, 28 also, but we don't like to exceed 30 under normal circumstances. However, if the intra-abdominal pressure is raised, then we can go up on the plateau pressure. Now, we can measure the intra-abdominal pressure by putting a foleys catheter or by certain apparatuses. So if we have a number on the intra-abdominal pressure, how do we actually decide what plateau pressure we can set precisely?
Okay, good question. That's a very good question. I think what most of the trainees need to understand is uh, plateau pressure, as we measure on the ventilator, is the pressure that comes measured at the lip, and we are extrapolating that pressure to the alveolar pressure because there is no flow at the time of measuring the plateau pressure. So we are saying that plateau pressure is a surrogate marker of alveolar pressure, but they also need to understand that in conditions like uh, thick chest wall, or when there's an increased intra-abdominal pressure, the compliance of the chest wall also gets affected. So the plateau pressure is not able to differentiate between a compliance problem of the lung and compliance problem of the chest wall. So the overall plateau pressure that we measure can be a combination of compliance of the chest wall and compliance of the lung. So how do we differentiate between the two? Because when you have an increased abdominal pressure, the chest wall also becomes stiff. So how can we say how much of pressure is actually being transmitted to the lung? Actually, if you want a right measure, you have to have, like the urinary catheter, some catheter that is can measure pressure in the pleura, and that is done by putting a catheter into the esophagus, and the esophageal pressure can be has been shown to correlate well with the pleural pressure, intrapleural pressure. And by getting the intrapleural pressure, we are looking at the transpulmonary pressure. Now, the transpulmonary pressure gives us a good idea of what the inflation and deflation pressures within the alveoli are, but not all of us have access to it. So when we don't have access to it, how do we go about? Now, animal and clinical studies have shown that when someone has a raised intra-abdominal pressure, when I say raised intra-abdominal pressure, anything greater than 12 millimeters of mercury of intra-abdominal pressure, going up 15 and above, we say intra-abdominal hypertension, and we grade it to 1 to 4 or 4 grades. About anywhere from 20 to 60% of that pressure gets transmitted onto the chest wall, and that is what we need to understand. So roughly, if you have an intra-abdominal pressure about let's say 20 millimeters mercury, you convert it into centimeters of water by multiplying with 1.3, it comes to about about 24 to 25 centimeters of water. About 50% of it gets transmitted to the chest wall. Okay, so 25, half of it, let's say about 12, gets transmitted to the chest wall. So we can safe if we say that your plateau pressure does not go beyond let's say from 30 goes up to 40. So that's the roughly done. There is a formula. Let me just, I've pulled up the formula. I can't keep. So the formula which has been given in most of the referrals are, it is your plateau pressure plus your intra-abdominal pressure minus 13 divided by 2. That is the total plateau pressure which is accepted. So roughly remember that about anywhere from 20 to 60% of the intra-abdominal pressure can be transmitted onto the chest wall. So again, I'm repeating, the equation that was used is your the intra-abdominal pressure minus 13 divided by 2. You add that onto your plateau pressure. That amount of pressure is what we can accept when we are ventilating a patient, keeping in mind that you do not cross a tidal volume of 6 ml per kilo, and look at the driving pressure. Try to keep at the driving pressure around about 15. This amount of plateau pressure is acceptable.
Thank you, sir. Thank you for the answer. Now, moving on to COPD. So, it's kind of getting cold, and we'll be getting a lot of COPD patients. So, they come in all shapes and sizes. Some are easy to ventilate. I mean, most of them don't even need ventilation. They just do with NIV. But there are these really tough ones, especially the chronic ones and the long-standing COPDs. And they have these exacerbations. They get ventilated. That is invasive ventilation, and you try to wean them, they don't come off. 2, 3 attempts, they don't come out, and you see the auto peep. There's no real auto peep, because if there's an auto peep, yes, you will try to reduce the auto peep before trying to say that we're having a weaning failure. So, what are the conditions? What are the causes of weaning failure in such patients, and what is the long-term outlook? What do we do with these patients?
Okay. Again, a very practical question. So, what we need to understand is COPD exacerbation is, when you ventilate and intubate and ventilate them, autopeep is just one of the problems that causes difficulty to wean. Now, main cause of autopeep is persisting bronchospasm or resistance that we have to treat aggressively. And you need to understand that even though the flow on your flow time scalar touches the um, baseline, there can be auto peep still present, which can be measured only by putting an uh, an end expiratory pause. So if you do not have a long apneic phase in the flow time scalar, when I say apneic phase, your flow time scalar, the expiratory portion should touch the baseline and go for at least a few seconds before the next inspiration starts. If it immediately starts off, even though it touches the baseline, but immediately starts, it could still have some internal peep, auto peep, which you have to look for by putting the expiratory hold and then treat the bronchospasm aggressively. That's one. Second, remember that most of the COPD patients who get admitted and get intubated have multiple comorbidities, would have been on steroids for long term. So all this will add on. So just like any other patient, look at why this patient is not, you know, uh, tolerating spontaneous breathing trial, why we are not able to extubate. Look for each parameters. The biggest culprit would be muscle weakness. On steroid, they'll have muscle weakness. They would be cachectic. The diaphragm might be weak. Look for these things. And a lot of times we may not be able to fix it. These are the patients who go into chronic ventilation. Second, look at your cardiac. All of them would have a cardiac problem. And when a patient is on positive pressure ventilation, the cardiac failure, even though very mild, might be what we call diastolic heart failure or heart failure with preserved ejection fraction, which gets completely masked on positive pressure ventilation. The moment you try to take them off, they fail. Look very close for that. look for nutritional problems, any electrolyte imbalance that can cause muscle weakness. Look for it and aggressively correct it. So don't think that it's only the lung. Look for other causes. Try to aggressively fix it before you try and extubate them.
Right, sir. Moving on to the next question is about cuff leak. So cuff leak, sir, is something as the trainees would know, we do to see if there is any laryngeal edema before we extubate a patient. And it is somewhat of a controversial thing. There are no proper studies to say whether it's helpful or not. But nonetheless, people do it, and it is something we should know about. So if the cuff leak is positive, sir, what is the process? How do we go about things?
Okay. So, like what you said, Tapas, the cuff leak test is not something that we need to do for every patient that we have intubated. And if you look at the guidelines, it very clearly says that you think of doing cuff leak test only for patients who are high risk of getting edema of the glottis or the supraglottic apparatus or of the trachea where we have intubated them, the tracheal mucosa gets edematous, and these patients fall into the group of who have been intubated for a prolonged period of time, more than a week, or had a traumatic intubation, multiple attempts at intubation, and in the process you have injured the vocal cords, the tracheal mucosa, or that, or mainly ladies, especially Indian Asian women, um, who are of petite stature. You intubate them with a larger endotracheal tube. We have noticed that if we use endotracheal tubes at size 8 for our women, they develop, glottic and subglottic edema. So use smaller size tubes for them. Patients who have a trauma, head injury, burns, all these patients are ones at the higher risk. In such patients, maybe doing a leak test, cuff leak test before you extubate may be helpful. Like what Dr. Tapesh said, the problem with cuff leak test is it has good specificity but low sensitivity. So if it is positive, that means there is no cuff leak, it tells you that there is edema. But if if there is cuff leak, it doesn't rule out, edema, and that the patient will have stridor when you extubate. So sensitivity is low, specificity is high. So it is not a good screening tool. Okay, remember that. So any test that has a low sensitivity is a poor screening tool. But if it is high specificity, it tells you that if it is present, you can say that there is glottic edema. And when do you say that the cuff test is positive? There are two ways that we look at it. We put the patient on volume controlled ventilation and look at what the inhaled and exhaled tidal volumes are. And when we deflate the cuff, there should be at least 100 to 110 ml drop in the tidal volume, telling us that there is a leak, or a drop in the tidal volume by about 10 to 15%. So if that amount of air leak is not present, then you say that the cuff leak test is positive. In such patients, you should be wary of removing the endotracheal tube or extubating them, especially when they are in the high risk group. For such patients, the recommendation is, few studies have shown that maybe 4 doses of steroid, dexamethasone, a dose of 4 to 8 milligram, 4 doses, maybe will give us a window to extubate it within the next 24 hours.
Right, sir. Thank
Tapesh.
you. So steroids have to be given in such patients. Now moving on to ABG. So a question on ABG is, I think we need to address anion gap, sir. So as we know, to really calculate everything, we need to do the anion gap in the ABG, and anion gap is influenced by the serum albumin level. And if the serum albumin level is low, we need to do a correction for the ABG. So here, sir, can you please explain why this correction is needed and what is the correction for a low albumin?
Okay. Um, again, a very practical question. Why do we need to correct for low albumin? Now, we need to understand what anion gap is. In a normal homeostasis state, there is a balance between the anions and the cations we have in our body. That means all the cations, the sodium, potassium, calcium, everything put together is equal. It's well balanced with the number of uh, anions. Okay. So, which will be chloride, bicarbonate, and all that. Now, what you need to understand is a large amount of the anions cannot be measured, or is not measured when we are doing the anion gap. And the largest part of the anion that is not measured is albumin. Okay, so when we are doing anion gap, which is sodium minus chloride minus bicarbonate, we are not bringing in albumin. So when we have a patient who has hypoalbuminemia, the gap happens because we are not measuring the albumin and phosphates. So when we calculate in normal conditions, there will be a difference of about 12 millimoles. So there'll be 12 millimole difference because of the albumin and phosphate not being measured. So think of a patient who has low albumin instead of being 4 grams per deciliter, it's only coming to, let's say, 2. The anion gap in such a patient will be falsely low because albumin is already low. So we have to give a correction for that. And the correction is usually for every gram of albumin that is less than 4, you add to anion gap to the anion gap 2.5. So if a patient's albumin level is only 2 grams, that means there is a drop of albumin by 2 grams. And if the calculated anion gap for such a patient is 10, you think, oh, it's normal, but you realize that the albumin is less by 2 grams, you add another 5, that is 2.5 into 2 plus 2.55. So actually his anion gap would increase from 10 to 15, telling us that actually it's a raised anion gap metabolic acidosis. So that is the reason why we give a correction for patients who are hypoalbuminic. And the same sort of correction goes also for patients who are hypophosphatic. So when phosphate levels are low, we give the correction of 1.5 instead of 2.5 for the albumin.
Yeah.
Tapesh.
Thank you, sir. Thank you. So moving on to the next question. Sir, we say that the lactate levels are increased when it's more than 2 millimoles per liter, but hyperlactatemia is defined as the situation where lactate levels are more than 5. So why is there a discrepancy here?
Again, a very clinical sort of question that we see in clinics. So the easy way to understand is, again, when you think about acid base, what we need to understand is the first system that comes to try and compensate for metabolic acidosis setting into the body is our buffering system. When you say buffering, hemoglobin, the phosphates, the bicarbonates, all that put together comes into the calcium, all that comes into the buffering system. And we need to understand that the buffering system mops up and corrects or compensates for the acidosis to a large extent that our body other different compensatory mechanism, which are the lungs and the kidneys, usually come in only later. Only once our buffering system gets overwhelmed, only then the lungs and kidneys come into play. So most of the time, we don't even realize the patient is in acidosis because the buffering system has already done a fantastic job. So let's take that lactate for the lactate is considered to be normal when it's less than 1. The moment it rises to 2, okay, there is hyperlactatemia. But there's no lactic acidosis because our buffering system has already taken care of it. So we'd say that So we don't call this as lactic acidosis, but it is telling us that our system is under stress. If you don't do something, this will go up. And once it goes up from 2 to 5, that's when the buffering system cannot compensate. And then the bicarbonate starts dropping, the pH, the pH becomes into the acidic side. That is when we call it lactic acidosis. So from, from 2 of lactate, there is already actually acidosis coming in, but we don't see it because of a buffering system. And that's why we don't call it lactic acidosis, even though we call that stage of 2 to 5 as hyperlactatemia. That is the point where we have to intervene and prevent patient from going into acidosis. Once it comes to 5, the compensatory mechanism of the buffering system can't actually uh, keep up with it. Then our lungs and kidneys start to work. We start seeing pH dropping and patient being actually acidotic. So that's the difference between the 2 and 5 in the lactate hierarchy.
Great, sir. Thank you for the answer. Then moving on to again sepsis only. So we have had CRP and Procal around for a long time, and Procal came with a big bang, but it has kind of fizzled out. And now there seems to be a new kid in the block, and that is presepsin. So would you like to tell us about this presepsin molecule?
Okay, now see the scientific world, the medical side, the scientific world is in a search for the perfect biomarker for sepsis, like troponins for myocardial infarction. So in that search, as I said, ESR, CRP, then came PCT, procalcitonin. So procalcitonin has been there for quite some time. And now we have realized that procalcitonin is not as specific and sensitive as we thought it would be in diagnosing sepsis. So we're on the lookout for another one. The new kid which has come is presepsin. Now, presepsin is nothing but a fragment of soluble CD14, which is released by the neutrophils and macrophages, which is the initial part of the innate immunity. So the macrophages and the neutrophils phagocytize the bacteria, and as the phagocytic action goes on, the uh, the soluble CD14 gets released into the system, and that is what is called presepsin. Now, um, investigations or studies have clearly shown that presepsin levels go up as early as 1 hour of a bacterial infection, and it's very short-lived. Its half-life is only for 5 hours. So it has an ability to pick up an infection very early, much earlier than procalcitonin, and has a very short half-life. So once you treat the infection and the bacteria are destroyed, the presepsin level comes down quickly, telling us that the patient has is improving and maybe help us with antibiotic stewardship too. So it has more rapid blood levels than PCT and a shorter half life. However, the problem has been that the sensitivity and specificity has not been any different from PCT. It is not freely available for bedside testing. And what we have seen is it also can be affected other medical conditions, especially renal dysfunction. So patients with chronic renal failure, acute renal failure, those on dialysis can have a falsely high presepsin. So we actually do not know what is the cutoff level of presepsin yet. Various studies have looked at it has looked at different levels. So yes, it's a promising molecule which is being studied, seems to be a good predictor of infection and its prognosis like PCT. But would it do better than PCT? We don't know yet. That is where we are.
Thank you, sir. So final question is about creatinine. So we all know creatinine is used as a marker of GFR given the limitations it has if it is still used in CKD patients as well as AKI. But in the ICU population, it is even more imprecise than CKD patients. So what are the factors in the critically ill which make it even more imprecise as a marker
Okay.
of GFR?
Okay. Again, um, when it comes to ICU, we are also on the lookout for uh, the best biomarker, which will tell us whether our kidney functions are going down and whether kidney injury is happening. Okay, there are many things that we'd like to know about kidney. Over the years, creatinine has been used as the marker for GFR. So, in steady state, when patients are not sick, when their the fluid level is not fluctuating, they are not in hyperdynamic circulation, like how most of our patients are, creatinine is a very good marker of GFR. So it has been used over years. Okay, you look at many studies, mainly in chronic renal failure patients, to allow us to calculate or predict what the GFR would be, and it has been an excellent tool. Now, again, I'm coming to sensitivity and specificity. It's a very specific marker. So if creatinine is going up, your GFR is coming down. There's no doubt about it. Majority of the time, there are other false indicators, like all of us know, creatinine, might be falsely low in many conditions. If all those factors are removed, creatinine is a very specific marker for renal failure, but it's not sensitive again. So when it is not sensitive, it is not a good screening tool. Now, creatinine, the biggest problem is creatinine lags behind the drop in GFR. The GFR has to drop quite a bit before creatinine goes up. So in ICU, it becomes a problem. Our patients, renal function would be going down. If we keep looking at the creatinine, it will not match with the GFR until the GFR drops to below 50s. So that is not good for us. The second thing is there are a lot of conditions in critically ill patients that keeps the creatinine at a lower level, falsely low level, especially in a what do you call it in a edematous state where your volume of distribution is high, creatinine will be falsely low. In patients who are on drugs, like steroids, thiametopim, all that, creatinine will be falsely low. In patients who are cachectic, muscle mass is low, creatinine will be falsely low. So in all these conditions, creatinine will be falsely low and may not help us in picking up a drop in GFR early. That is the biggest problem with it. But once the creatinine starts going up, we can very clearly tell that the GFR is dropping, and that's why creatinine has been used in a lot of the formulae that have been used to calculate GFR, and most of the guidelines even now use creatinine for diagnosing a drop in GFR. Again, it's not the best biomarker we have, but it is the most studied, and people feel comfortable with it, so we continue to use it. We are on the lookout for better biomarkers. Cystatin C is one that is coming up now. Biomarkers like NGAL, which are markers for renal injury, not GFR, is also coming up. NGAL will tell you very early that renal injury is happening even before the GFR starts dropping. So these biomarkers are around the corner. Maybe with more studies that will come into monitoring of our patients. So yes, creatinine is not the best, but that has been studied over the years and still plays a big role in our monitoring of patients with renal failure.
Great, sir. So thank you, Babu Ram, sir, for answering all
Thank
these
you.
questions in detail and explaining so nicely. I'm sure the audience must have enjoyed it and learned a lot. Soon we'll put it up on our channel for everybody to see. Thank you very much, sir, and I thank
Thank
the
you.
audience for the patient hearing. Good night, everybody.
Good night.